I'm Hala Ali, the coordinator of ESTHER Alliance for Global Health Partnerships and ESTHER Ireland. These webinars take place on Fridays at 12 p.m. GMT, and every week we host experts from healthcare and global health fields to discuss various aspects of the COVID-19 pandemic. We are delighted today to co-organize today's webinar with GIZ, the German Agency for International Cooperation, and THET, Tropical Health and Education Trust. GIZ offers consulting and capacity building services in a wide range of areas, including management, consulting, sustainable infrastructure, security, and peace building. THET is a specialist global health organization that educates, trains, and supports health workers through partnerships, strengthening health systems, and enabling people in low and middle income countries to access essential healthcare. For more information about GIZ and THET, please visit their websites. The title of today's webinar is Leaving No One Behind, Keeping Up Essential Services for Non-Communicable Diseases Patients in Ethiopia during the time of COVID-19 response. A recording of this webinar will be available in our website and YouTube channel shown on the screen, Irish Global Health and ESTHER Alliance for Global Health Partnerships. Live streaming is also available right now on our YouTube channel, Irish Global Health Network. If you have any questions during the webinar, please use the question and answer feature in the bottom of the screen. We are excited and delighted today to welcome our moderator today, Prof. Mirgessa Kaba. Prof. Mirgessa is an associate professor of public health at the School of Public Health at Addis Ababa University, with his proactive focus on the areas of social and behavioral health. For now, I will hand it over to Prof. Mirgessa to introduce the speakers and lead the panel discussion. Welcome, Mirgessa. The floor is yours.
Thank you so much, Hala, for your kind introduction. I'm so happy moderating this session from Ethiopia. Non-communicable disease in Ethiopia is one of the emerging concerns of public health threats, and with COVID, obviously it is getting complicated. And today's session basically is going to look into those details. Today, we have a number of speakers. Please allow me to introduce each one of them so that you would also connect faces to speakers. The first one is Professor Adamu Adise. Professor Adamu is from the School of Public Health at Addis Ababa University, from the Department of Preventive Medicine. He is one of the founding chair of the Non-Communicable Disease Epidemiology Research Working Group within the school. And he is also the founder of Field Epidemiology Training Program within the School of Public Health at Addis Ababa University. Currently, Dr. Adamu coordinates COVID-19 emergency operations response within the Tukur Anbassa Specialized Hospital. Tukur Anbassa Specialized Hospital is one of the biggest and probably the only tertiary level hospital in the country. After him, we have Miss Bezawit Katama. Bezawit Katama is a lecturer within the same school, the School of Public Health at Addis Ababa University, Department of Preventive Medicine. With clinical nursing background, Bezawit has done her master's in public health and is currently doing her PhD at the Martin Luther University Halle in Germany with a project that looks into increasing non-communicable disease screening practices in rural setup of Ethiopia. She is also playing an important role within the advisory council of COVID-19 response in the country. Following Ms. Bezawit, we have Dr. Dasalo Makonnen. Dr. Dasalo Makonnen is a consultant internist and a cardiologist at the Tukur Anbassa Specialized Hospital College of Health Sciences within the same university, Addis Ababa University. He is also an associate professor at the Division of Cardiology, Department of Internal Medicine. And he is also the current president of the Ethiopian Society of Internal Medicine. Following him, we have, I have the pleasure of introducing Dr. Yosef Mammo. Dr. Yosef Mammo is TENA country representative. TENA in Ethiopian language, in Amharic language, means health. And he's a qualified medical doctor, general internal medicine. He had been working for Jimma University chronic disease project and is an advisor for the NCD case team of the Ministry of Health, which is supported by THET, Tropical Health and Education Trust in the UK. Between 2016 and 18, Dr. Yosef worked as a volunteer consultant at Hospice Center in Ethiopia and patient care at Washington Medical Center. The past 2 years, he has been leading the THET effort to support the Ministry of Health to decentralize non-communicable disease prevention and control program. Finally, we have one of our speakers from the Addis Ababa Health Office, Mr. Wenderson Barrier. He's trying to connect. He's a nurse by background with a bachelor degree in psychology and is currently the NCD team leader of the Addis Ababa Regional Health Bureau. He will be joining us, I hope, soon. Each of our speakers will have 8 minutes, and I'll remind them when they remain with their 2 minutes so that we can have more time for discussion. And the participants are kindly requested to drop their questions in the drop box. We have chat box, so in that chat box, if you leave your questions specifying to whom it's meant, then we will pick those questions and continue. With that, I think we can move to the next speaker. Buhari, do you have anything? Yes, please.
Okay, so I'm just starting to share my screen, and Ellen, you just need to approve it as well, I think.
Yeah. Professor Rari Buga is a webinar anchor, and he's a former head of epidemiology and public health at RCSI. I'm very sorry to keep it as abbreviated as it is in Ireland, but you may tell us what that means, Professor. Please go ahead. The floor is yours.
Okay, thank you, Professor Kaba. Is it coming through, Ellen?
No, not quite yet.
Have you approved it?
Yeah, you should be good to go.
Yeah, it just seems to be a little slow coming through there for some reason. Are you seeing anything?
Not quite yet.
Yeah, I think if it doesn't I have it as desktop, but
no problem. I share it through.
Oh wait, I didn't do the share. Maybe that.
There you go.
Oh,
Perfect.
very good. Yeah.
I'm very slow, Professor Kaba. Firstly, just to say how delighted I am to be part of this. And as some people know, Ethiopia is going to be a very special country for me. And I look forward to meeting many of you once I move to Addis Ababa, which I don't know will be before the end of the year or maybe at the beginning of 2021, depending on the epidemic. So as many of the listeners know, we do just an overview of the COVID-19 epidemic, and trying to do a screen. There we are. So in this first slide here, this is just an overview I gave Irish Aid for Department of Foreign Affairs yesterday, just a reminder of how COVID-19 affects people. And the real problems are when the infection moved from the nose and the throat to the lungs. And these are some of the clinical findings that cause the major problems: the shortness of breath, the hypoxia. And a reminder that oxygen is the most important treatment. You don't need mechanical ventilation to manage most cases. But where the longer term residual effects are and how it can sometimes affect younger people is through this cytokine storm, which is an overreaction of the immune system that leads to blood coagulation, blood clotting problems across the different body systems. One of the reasons I put in this slide is because the risk factors, the ones both here in high income countries, but also low and middle income countries, are actually, many of them, the subject of today's webinar, the non-communicable disease conditions. Case fatality rates depend on how many cases are being picked up, much greater than influenza. But we do need to remember that most people, including 80% of those over 80 years of age, do recover. I put in there asymptomatic as 10 times more common than symptomatic infections. But actually in sub-Saharan Africa, we're probably seeing an even higher proportion of asymptomatic infections. This is a slide that we show each week, and I'm not going to dwell on it today, but I did have figures 2 days ago and found there were quite a lot of changes just over 2 days. I've only put in a comparison over a period of 3 weeks there for Ethiopia, just to show not only is Ethiopia presenting 5 times as many cases over the last 2 weeks, over the last 3 weeks that should be, but also if you look right over to tests per million population, its testing capacity has been ramped up considerably. So here's a slide which is a new one, and one of the reasons is because I just want to draw your attention to this paper which came out in Science on the 10th of June. It includes authors from the Imperial College Group, and these are the sort of modeling epidemic curves that we've seen from them. This one here is showing 2 different things. It's showing, if you see the curves there on the left, it's daily mortality rates per million. And this very high curve shows in the presence of a poor response by the health services and with very limited healthcare, we're going to see much higher mortality rates. Whereas here with a poor response, let's say a lack of closures, a lack of physical distancing, but a more effective healthcare response, we're seeing lower mortality rates, about 1/5. Here is where there's a more effective response on this side. The mortality rates are much lower, but they will depend on the effectiveness of the healthcare system. And I think that's relevant to today's presentations. Here's another new slide, and it's actually based on a paper that I just haven't read properly up to now. And because of today's webinar is about leaving no one behind. It's about the effects on the more vulnerable, the poorer populations. And this is modeling work that was done by the Imperial Group. And while I don't think you can always trust their models in terms of the numbers, there's a very good analysis in there about the differences between the wealthiest 20% and the poorest 20% in low and middle income countries. And it's just drawn out 3 factors there that would account for a 32% higher death rate among the poorest 20%, geographical and financial access to healthcare. So that's relevant to today's webinar. But then these other factors, if Niall is on, he'll be glad to see hand washing in there. Occupational risk, Father Michael Kelly has drawn attention to that, and the gender dimensions. And here are just other risk mediators that impact on poverty: age and household structure, food insecurity, and vulnerable and displaced populations. They don't talk about these other comorbidities, but I put them in because they're particularly relevant. The NCDs that we're going to be talking about today, which, and I suppose the question to the panel, in high income countries like Ireland, we actually see a higher prevalence of some of these conditions among the poor. populations. But what's the situation in Ethiopia? Because it may be that, say, obesity might actually be more common among wealthier population, where in Ireland, we actually see obesity more common in the poorer population. And then there's the infectious diseases. I'm just going to shoot through a few slides now quickly. I think there may be parallels between the impact of COVID-19 on mother and child health, which we looked at 2 weeks ago. I think the next slide is more interesting in a way, because here we're picking out some of the particular dimensions of care which are being affected by COVID-19 or being affected by the responses to COVID-19, particularly where lockdowns happen. And it's about the drug supply, in particular, access to a clean birth environment. That's for women who die in childbirth. Malnutrition, wasting, a major factor which can result from lockdowns, but also can be contributed to by COVID-19 impacting on food supplies. But these other ones really relate to the healthcare system and how it is affected by COVID.
So 2 minutes, Rory. Great,
thank you, Professor Kaba. We've looked at this one before, and there may be parallels with NCDs and how HIV/AIDS and tuberculosis are impacted in particular. We've looked at a similar model earlier, but I'm just drawing attention to this issue, which I will be looking forward to hearing the panel on. How is the response? Are there closures of neighborhoods maybe impacting on people's ability to access healthcare? And that raises the issue, what are the appropriate responses? So I'm hoping the panel will talk to how the responses to COVID are supporting or undermining the responses to NCD management. This is a slide we show often. There's an update on the link to it. Probably the best publication from WHO that's come out in terms of LMICs, and it came out quite early on in March, and I think it's a relevant one that might be relevant today. Final slide. And I'd just like to draw your attention again to a new paper out in Global Health, well worth reading. You've got the link to it there. And it's about what the middle ground should be, particularly in low-income countries such as Africa, not aiming for full suppression, aiming to limit the spread, mitigate the harms that come from COVID, but the harms that come from control efforts that may not be appropriate to the setting, and shielding those at risk. So many thanks, Professor Kaba. Really looking forward to this webinar, and perhaps I will come in later.
So thank you so much, Professor Rory. This is quite useful slides. So just a reminder for the rest of the speakers as well, 8 minutes means 8 minutes. And for the rest of participants, please note that we'll be running for an hour and a half for this particular seminar, unlike 1 hour seminar that you have earlier, because we have more speakers. So we move to Dr. Adamu, who will be talking about the COVID situation in Ethiopia, as well as share with us experiences with NCD within the School of Public Health at Addis Ababa University. The floor is yours, Dr. Adamu.
Thank you very much, Dr. Mergisa. And I would like to thank the organizers of the event for the very kind invitation and the coordination of activities around this topic. So I am Adamu Addise. I'm from Addis Ababa University, based at the School of Public Health, and closely work with the NCD epidemiology working group. And I'm asked to speak on this topic, the COVID-19 updates in Ethiopia. So I will focus more on that. And I thought I had 10 minutes, but Mergisa just said 8 minutes, so I will try to move as fast as possible. The outline of my presentation will be as follows. I will give a very brief overview of the national situation epidemiologically, but also what response measures are there, and a few points on currently observed challenges in the COVID response. And then I want to briefly also introduce the NCD epidemiology working group at our university and our collaborators. So coming to the COVID-19 situation in the country, the first report of a case was made in the 13th of March, 2020. That's about more than, I think, a little more than 12 weeks. And when we see the trajectory, so we have had a very slow build-up of cases over the last about 10 weeks. And then suddenly we have a surge of cases, as was reported by the earlier presenter. And as we stand, as we speak today, I haven't looked at the report, the really report for today, but based on the latest update from yesterday, we have close to 4,000 confirmed cases reported and 65 deaths related to COVID. And so to reach to the first 1,000, it took us about 77 days, according to a report released recently by EPHI. And the next 1,000 was attained only in a week time, so another 7 days. So you can see how fast the number of cases is increasing in the country. So if you visit the Worldometer, usually gives you a live update of the situation. And we have close to 1,000 recovered from it. Just few graphs, as you could see, you know, where it looks like we are just climbing up into the AP curve. So, you know, now the direction is in that line, and the number of reports of new cases is also increasing. So we have reached to 3-digit reports, so like the hundreds. That's what I mean. And it might possibly increase. This is a country of 110 million, and yeah. So as the infection goes out of Addis, we might possibly have a different picture in the coming weeks. The same with the number of cases. As the number of cases increased, the number of cases also is increasing, and again we are climbing up in the graph. The same with the number of cases reported on the daily basis. So this is a chart showing the number of active cases. The epicenter is in Addis, the capital, and within Addis we have some sub-cities out of the 10, some sub-cities which are epicenters within the epicenter, like the Addis Katama, where we have had the national bus coach station. And a lot of overcrowding and petty trade in that area. And this continues possibly to be a challenge in the coming weeks again. When we look at the profile of cases reported, I mean, according to the reports we have so far, most of the confirmed cases are without symptoms, more than half. And then the next majority are those with very mild symptoms. So those with moderate and severe symptoms are very small. I apologize for the quality of the graph, but this is the gray curve is those with moderate, and the yellow is with severe. So fortunately, we have less proportion of severe cases on those on critical care, and this might possibly continue, and this could be explained by the predominantly young population that we have. Possibly there could be also other factors. Coming to the national response is led mainly by the Ministry of Health, and the minister is at the top of all the major activities nationally, and she gives daily ministerial briefings on the situation on daily basis. And the National Public Health Institute, EPHI, it stands for Ethiopian Public Health Institute, is in charge of most of the technical aspects like the testing, contact tracing, and other support activities, including coordinating treatment centers. And the Ministry has developed several guidelines, including about continuity of essential services, geared after, I think, the WHO guideline mentioned earlier on. And there are several advisory teams composed to advise the minister and her team on how to go about the response, and they are heavily engaged nationally. There is also a national task force and a ministerial committee led by the Prime Minister, and a state of emergency is already declared, as my Ethiopian colleagues would know, to support most of the public health interventions and guide policy interventions as well in the time of a pandemic. And just a week ago, our election, which was due to be conducted in the summer, is postponed officially by the parliament. And there are non-pharmaceutical measures, again, implemented all over the country. Universal masking, hand washing is now a trend in most places, especially public places. There are also measures related to reducing the number of those riding in public transports by half. And there is also repurposing of the health system by allocating facilities into COVID and non-COVID treatment facilities. And the testing also has been ramped up over the last months, especially, and we have over 40 testing centers in the country. And as was reported earlier on, Ethiopia has one of the highest figures of testing compared to cases even globally. And this is a Millennium Hall, an exhibition center turned into a treatment center, a 1,000-bed treatment center close to the airport. Some of the challenges to mention include adherence to the non-pharmaceutical interventions, like social distancing, to mention. And I mean, the response actually was, the response was very high at the early days, in the first week of when we had the first case reported. But over time, it looks like there is some, yes, some leniency, and so this is an observation actually. Apart from that, it is a challenge also to maintain hand hygiene, because the facilities we have at the public areas as well as at home are not conducive in general. There is high family size, and the number of rooms per family are not optimum. So there are lots of challenges associated with that. Health-seeking behavior, again, due to some of the factors mentioned by the earlier speaker, we have observed low turnout to health facilities by clients and patients, and has affected the maintenance of some essential services. So we have moved into a community spread transmission, and the coming also continue to be a challenge. And possibly we'll have some mortality associated with that, and we need to be ready to handle this. There is a universal problem of PPE, personal protective equipment, especially for the healthcare workers, and we have also a good number of health workers already affected by the virus. From the social angle, there has been a high degree of panic associated with this, even from the medical professionals. We have witnessed levels of stigma and discrimination, and even reports of suicide because of this. And there is a lot of wrong information flowing in several directions. So the infodemics is another problem which is parallelly running across. And the health system has COVID on top of other health priorities. Thank you. On top of other competing priorities. So maintaining the right balance is a challenge for the health system. So it's just to mention a few of the challenges among several. Just to briefly take you through what's happening at the National Hospital, the ጥቁር አንበሳ Hospital, which is a national referral and teaching hospital with a capacity of 1,000 beds and over 2,500 health workers. So the hospital started its preparation in response as early as the first report was made, even before actually, and tried to lead the response in a very structured and informed planning process. So this is the list of events actually which took over since mid of March. So we have conducted a readiness assessment in the facility and moved into preparing an emergency preparedness plan. And we have started continuously monitoring the capacity of the facility.
Sorry, Dr. Adamu, I'm going to stop you. Can you wrap? Sorry, can you wrap in a minute? I'm going to stop you. Sorry. Just in a minute, wrap up. Thank you.
Yeah. So this is the assessment in the plan. We have an emergency operations center, and these are the different teams. There is a team also looking at case management and maintenance of essential services. Finally, just wanted to tell you about the NCD epidemiology working group at the School of Public Health, which works on generating evidences related to non-communicable diseases for policy and program at a national level. And we have been working on several research projects, academic, but also implementation research, and trying to disseminate those over the different fora we had. We have several partners, and our main partner has been Martin Luther University from Germany. Through that link, we have had several support from the German government, including GIZ, and we closely work with the Ministry of Health in Ethiopia, and we continue to work on the same angle. Thank you very much for your attention, and apologies for taking a few minutes over. Thank you.
Thank you. Thank you so much, Dr. Adamu. He was presenting two different things, so you can imagine why he has taken extra minute or so. So we move to the next speaker, Ms. Bezawit Katama. She is going to share with us the voices of the public with respect to NCD services, as well as the voices from the providers. So the floor is yours, Bezawit, and keep the 8 minutes mark. Thank you so much. Go ahead.
Thank you, Dr. Melissa, and greetings to everyone. Thank you, the organizers, for having me here today. I'm delighted to share you what I have based on the qualitative study that me and my team have conducted. And for the study entitled Non-Communicable Disease Management at the Time of COVID-19 in Ethiopia, we have interviewed 22 study participants, NCD patients and healthcare professionals working in the management of non-communicable diseases with the objective to explore the challenges and coping strategies in NCD management during COVID-19. Therefore, this presentation today is going to be from the voice of my study participants, as precise as possible to fit the 8 minutes. So the presentation is basically address the challenges posed by COVID-19 and the coping strategies. So the first one is challenges posed by COVID-19 in the provision of NCD services. As per the voice of NCD patients, they forwarded fear of COVID infection, transportation problem, absence of social and economic support, and not welcoming healthcare facilities, and stress related to high-risk perception as a challenge. And a typical 52 years old hypertension patient, for example, said, even if we could manage the transportation problem, we are still afraid of acquiring COVID-19 in the healthcare facilities. So we prefer to stay at home at all. For that, I quit my work, said by a 52 years old hypertension patient. Another typical response by an old woman, diabetic patient, she said that before COVID-19, my neighbors used to visit me almost every day, and they were a lot of financial and emotional support, and nowadays nobody is coming. And she said that there is a lot of challenges in taking her medication even. From the voice of the healthcare professionals who are working in the management of non-communicable diseases, they verbalized that currently there is a decreased NCD patient flow by 40 to 60% as they perceive, and they fear that the clients might discontinue their medication. So a typical nephrologist working at a public hospital in Addis said that nowadays we came to finish our morning card at 11 a.m. Whereas before COVID, we had been working on the morning cards until 1 p.m. So this shows that the decreased patient flow, NCD patient flow to the healthcare facilities. And with regard to health education to the NCD patients, a nurse who was working in a diabetic clinic verbalized that after COVID, we stopped giving health education, and what is very pertinent for our patients. So she emphasized that this educational component is very pertinent, especially for those diabetic patients on how to take their medication and their diet and other things. So with regard to the phone clinic, there are a lot of challenges that the healthcare professionals have forwarded. And for example, a resident diabetic DM specialist who is working in a public hospital said that we don't have a special training in conducting this virtual clinic or phone clinic. So we are challenging a lot and we are stressful, especially in deciding the appointment date or where, when to appoint the clients, whether to allow them to come, invite them to come to the facility or to delay and so on. So apart from the challenges, both the NCD patients as well as the healthcare professionals have developed their coping strategies, and as per the voice of the clients, they almost all say that homestay or staying at home as a best strategy because they are at a high fear of acquiring COVID-19 while they are getting out of home. So that they say that nowadays, for example, a typical NCD patient say that nowadays I do not even go out for groceries. For example, today I came here to take my medication, but I came by walking for 2 hours almost. So she is afraid of taking transportation and so on. But almost all NCD patients show that they are almost giving up. They are in a high fear, so that they are just waiting for a miracle, for a divine intervention or something from higher power. So most of them say that almost unless God does something for us, unless God protects us from all the bad outcomes, we are at a higher risk and we cannot manage by our capacity. So that shows that they just gave up, and this is from the old man colorectal patient. But from the healthcare professionals side, they verbalize that they are using strategies to manage this COVID-19 for a continuation of this NCD service. And they almost all are using virtual clinic, even though it has a lot of challenges. So a cancer specialist gave us a typical response. She said that even though the phone clinic by itself has a lot of limitations, we are managing our clients virtually over phone to minimize their risk of acquiring COVID infection while they are coming to the healthcare facilities. But like incomplete information, for example, some patients do not have their contact information in their patient card. Maybe for those who have their contact information might not be available by that number and so on. So a lot of challenges they have forwarded. Other than that, as coping strategies, they mentioned a community engagement, especially at the primary healthcare facilities. They say that, for example, a typical NCD focal person who is working at the primary healthcare facility said that healthcare professionals currently going house to house for COVID-19 testing. And now, while they are going to house for that purpose, they are asking as well for a presence of NCD patients, and if there is an NCD patient, and if that NCD patient has any health need or any health problem, and so on. So this is what we call a community engagement. So this phone clinic, usage of phone clinic and community engagement are typical coping strategies forwarded by our study participants, healthcare professionals. So upon this brief verbalizations,
Bezawit, you have a minute and a half.
Upon these verbalizations, we have concluded that the postponement of the routine medical appointments and the NCD management may disrupt the continuity of care for NCD patients, and this disruption of the routine health service together with the stress and avoidance of physical activity might increase morbidity, mortality, and disability for those NCD patients. So that we recommend that any COVID-19 prevention and control strategies at all levels to target NCDs differently. So thank you so much for your time and attention.
Very good. Thank you so much, Bezawit, for this excellent presentation. So we move on. We will have our next speaker, Dr. Dasalo Makonnen, a consultant internist and a cardiologist, who would actually tell us experiences within the Tokur Ambassa Hospital itself. So the floor is yours, Dr. Dasalo, and 8 minutes.
Okay, thank you very much, Dr. Migasa Kaba, and the organizers of this conference. So I am the outpatient director of the Tokur Ambassa Specialized Hospital, and the physician by profession. The Tokur Ambassa Specialized Hospital is a tertiary care facility of the country, having 51 specialty, subspecialty, and super specialty clinics, and we see 500,000 patients per year. And majority of our patients will have non-communicable disease, having a regular follow-up, and the pool of patients are increasing from time to time. Following COVID, after March 13, 2020, after the first case of COVID was detected, we face challenges from our patients, that especially the second week of March and the third week of March, majority of patients disappear from follow-up and lost to follow-up. They reduce visit to outpatient clinics. We face also a lot of anxiety and panic among healthcare professionals as well as patients. And for this problem, there was also a trend that encouraged patients to stay at home. And it was a universal announcement that majority of patients are not coming. And there was also travel restrictions, as you remember. And we have a reduction. About 40% of our patients who are expected to come to the hospital disappeared. So for this problem, we designed a local solution by implementing a phone clinic. We just discussed with physicians running these clinics, the non-communicable disease clinics, and physicians tried to call to patients 1 week ahead before their appointment, because some patients already, if we call them on the day of appointment, some are either they come to the hospital or they are at their on the way to the hospital, or they are in the hospital. So we start calling them 1 week before their appointment and try to manage them. But still, we face challenges in implementing the phone clinics. One, we don't get their contact number appropriately, so we are implementing electronic medical recording, that we record every information of the patient, especially for adult patients. But still, patients might not have their own contact number. And also it was a surprise for them as well, receiving a call from a physician. So there was some challenges, but later it became better now. And we did an assessment for the 8 outpatient clinics in the Department of Internal Medicine, and we compared with the previous month's visit. For example, in December 2020, we have seen in December 2019, we have seen 9,405 patients, but in April 2020, we see 7,038 patients in the 8 outpatient clinics of internal medicine in non-communicable diseases, and there was 2,000 patients lost from follow-up, but we tried to reach around 1,352 patients through phone and we tried to manage them. And these phone clinics are run by physicians, volunteer physicians who are running the clinics, and they call by their phone number, and they take these patients as a cohort of patients, meaning they follow them, they receive their complaints and try to optimize their medications. If there is any to come to the hospital, they also evaluate these patients at the hospital. By implementing this, we tried to help a few patients, but still non-communicable disease care and treatment service is seriously affected. We can't screen patients, we can't effectively diagnose, we can't effectively treat, and we can't also effectively follow and manage patients because of these problems, and patients are discontinuing their medications. For example, I'm a cardiologist by profession. 2 of my patients discontinued their anticoagulant warfarin and developed a stroke from atrial fibrillation in the month of April. So as a solution, we have to have experience sharing from other centers, if any, so that how can we implement case management services, adherence and support services to these patients, because we have seen good adherence to those diseases having a program like HIV. For example, in our ART clinic, the loss to follow-up is less than 5%. Majority of patients are on treatment. When they are absent, there is a system that we call them and we track them. There is a mechanism for loss to follow-up tracking mechanism, but we don't have a mechanism for other non-communicable diseases. For example, in diabetes, we don't have that type of service, so that when a patient is absent from follow-up, we don't have a mechanism to monitor. We implemented, okay.
2 minutes, Dr.
Okay. For example, we implemented a nurse-led clinic in our hematology clinic, chronic myelogenous leukemia, CML clinic. In that clinic, for example, we don't have loss to follow-up because the nurse regularly call to patients and follows them. But this practice is not happening to other non-communicable diseases, including cancer. So my recommendation is, if we have an experience from other centers, that we can collaborate on this issue. And if we provide mentoring in this program, and also if we engage the community health extension workers in this program, would be good. So this is my presentation. Thank you very much.
Excellent. Thank you so much. Indeed, this is really in time. So we move to the next presenter. That's Dr. Yosef Mammo. So Dr. Yosef, you have 8 minutes, and the floor is yours. Meanwhile, please, participants, you can put your questions in the chat box so that we can actually address them after the presentations. Dr. Yosef.
Thank you, Dr. Melgisa. And I also would like to thank the organizers for an opportunity to speak. My name is Yosef Mammo, and I will be sharing on behalf of the THET Alliance some of our work and some of the scenario in the rural health centers. First of all, let me say something about THET Alliance. This is an alliance working towards increasing access to NCD care in rural poor Ethiopia. It is a partnership of THET, Southampton University, Gondar and Jimma chronic disease projects, and also recently HPA, Health Poverty Action, or otherwise known as Health Limited in Ethiopia. The purpose is to synergize our interests, experience, and capacity on health interventions for the rural poor. So THET has a rich experience in building partnership between UK and Ethiopian health institutions, particularly teaching institutions. Southampton University is engaged in community health research, and Health Limited works on communities, hard to reach communities such as pastoralists. So I think it's a good combination. The strategy is a chronic care model, which a lot of Ethiopian health workers know as a kind of HIV program, how it is established. So a similar kind of, the same model of decentralization of care for access through task shifting or sharing to mid-level or frontline health workers, as well as task simplification. And when we do, it is anybody who's familiar with HIV work would find this very familiar. It's a capacity building, training, setting up services, medical recording and reporting, the consolidative work, working on quality, mentoring, supervision, reducing loss to follow-up, sharing best practices, and access to essential medicine and supplies, and the demand creation, where health extension workers will go down at the community level, raising awareness. There will be mass education, improved health-seeking behavior, and screening campaigns to enroll into the services of these rural health institutions. So it is, the Ministry of Health has been working on this for the last 10 years, preparing documents, plans, strategies, and so on. But it's only until 2 years ago that partners have appeared and donors have appeared to help a little bit, a drop in the ocean, you may say. So there are, other than us, there are 3 other partners, PSI, QAM, and Resolve to Save Lives, and also Pathfinder, specifically working on cervical cancer screening. So we particularly work on 60 facilities, most of them rural, 15 hospitals and 45 health centers. The rest of the partners work on 180 facilities, and together about 240 health centers, facilities are covered. This is, as I said, a drop in the ocean when you think of the 3,000 health centers we have in our country. So we work in 6 regions, and this is closely supervised by the Ministry of Health so that partners do not duplicate or unnecessarily. So we work in 12 semi-urban health centers and 24 rural health centers. So our interest mainly is access. So at this time, the rural people do not know much about NCD. You have to increase the awareness so that they can utilize the facilities. So the flow at this stage in rural health centers may be very low, but it's an important step to educate our people. So with regard to challenges due to COVID, I think, I'm afraid I will be repeating what probably Bezawit and Dr. Msganau were saying, but what we can say is it's not as palpable. The problem is not yet as palpable as we see it in Addis and most major cities. But one thing is for sure, there is a fear among health workers as well as patients. So the health system, as a result, you can say there is a paralysis of uncertainty of what to do. Services are almost in most appear to be in a standstill. Health workers are afraid to get infection, take it to their homes, to their families. Rural patients are very afraid, as you know, to come to densely populated towns and cities. And in the early stage of panic, there was also restriction of movement. As a result, patients' attendance was affected. Of course, there is lack of confidence also going to the hospital, not only towns, because that's where patients, rural patients think the infection comes from. The supply chain is of medication and other supplies.
2 minutes, Dr. Yusuf.
Okay. Okay, is also a problem because of a very clear reason that all of you are aware, the supply chain, the competing priorities for COVID, and as well as the international problem of shipping and others have resulted in serious shortage of medicines. That's the complaints we hear from many of these rural clinics. And patients have to be referred to private pharmacies, and that is a problem with out-of-pocket cost increasing. Redeployment of focal people, good workers are moved to work on COVID. Health extension workers are fully engaged on COVID. To a certain degree, it's very good, and we expect that to happen, but it will definitely harm the service to NCD. Mass campaigns cannot be done because of the social distancing, and there is difficulty of screening, even measuring blood pressure, taking blood glucose measurements because of the proximity and the policy that without PPE you cannot do that. So these are some of the problems. The responses, briefly, we tried to send, triage do not exist in most of these rural clinics. We tried to establish those, and also distribution of infection prevention protocols through the PAC guideline, as well as investing more time on mentoring on these areas, frugal innovation, so that they can make their own masks and face shields. These are some of the efforts. Telephone communication of patients, reporting data by telephone, and so on, and other supporting financially local support, supervision and mentoring. Ministry of Health's team has been out and assessing on the ground, and they have an assessment, but they could not come and attend today. Maybe in the future we can share that. Thank you, Dr. Kaba, back to you.
Excellent. Thank you so much indeed. Again, you are in time. That will allow us for more questions to come. So the last but not least presenter from our side, I hope he's around, is Mr. Wenderson Berhe from the Addis Ababa Health Office. So the floor is yours, my friend Wenderson. I understand Mr. Wenderson has connectivity problems, but I realized he was in. Wenderson? So, Dr. Yusuf, can you take off your screen, please? Can you stop screen sharing, Dr. Yusuf? So very good. Well, I think we don't really seem to get hold of Wenderson Berhe from Addis Ababa City Health Office. Then this would basically give us more time for discussion. We have several questions. Dr. Yusuf, can you please remove your slide share? Do you hear me? You just say leave. So excellent. So very good. Thank you indeed. All the speakers, they really shared interesting reflections on those issues. And there are a number of questions that have come from. And for Dr. Adamu, there are a couple of questions. The first one is if you have any information on, it's very general, update on access to remdesivir drug for Ethiopia. And the second one is on community screening with respect to antibodies. Is there any experience for Ethiopia? If you could just, reflect on those ones, and then we will move forward to others.
Thank you very much, Dr. Mergisa. So regarding the first question, whether there is a remdesivir, I don't think so, but maybe, I'm not involved in the clinical management. Dr. Dasalo could possibly also, but as far as my information goes, I don't think this antiviral is available in the country. About community screening with antibodies, this is not again officially integrated in the current public health monitoring strategies, but this is under consideration. And I was involved in one exercise where serosurveillance was piloted through a cross-sectional serosurvey in Addis. And we have found some interesting, we have observed that there is an extent of exposure to SARS-CoV-2 more than what we would have would say is there based on the RT-PCR. So we have made a recommendation that this should continue, and I think there is something going on at the ministry level, and we have also planned to move into community-based screening. There are issues I have seen also in the comment related to the quality of which test to use, sensitivity, specificity, and the like. And we are also doing some validation in the country. So hopefully this will follow suit soon. Thank you.
So thank you so much. Thank you. I very much appreciate that. There are a couple of questions for Bezawit. What to do to address the concerns of NCD patients? I mean, you have highlighted some of the concerns, but then what is it that you would say in order to address those concerns? And what is the role of health extension workers in dealing with NCD patients during this difficult time? Is there anything that you would say? And perhaps we will follow up with the same question again with Dr. Dasalo as well. Yes, Dr. Dasalo. No, Bezawit, sorry.
Okay, Dr. Melgisa, thank you so much. For the first question, what to do to address NCD patients' concern? Normally, we as a team who have conducted this research, we recommend that all prevention and control strategies in the first place, all means maybe the health communication intervention, maybe the budget for research, or any kind of strategy for the prevention and control of COVID-19 should target NCDs separately. So should give a separate and like a bigger attention for NCDs. So by that, we can address our NCD patients' challenge and concern. For the second thing, the role of health extension workers, we basically conduct this study in Addis because at the time of our study period, the regionals or the regions and the capital city Addis are in different states in the spread of COVID-19 in the country. So when community transmission is there in Addis, that might not be there in regional areas and so on. So all the things, the challenge and even like the healthcare facility visit or the awareness level, everything is different from Addis to the regions. So that we focus on Addis separately from the regions. But in general, these health extension workers are mostly more involved in regional areas or in the regions. But as we recommend and as our healthcare professionals who are participating in this study recommend this community engagement by which when healthcare professionals go to house for COVID testing, they ask for NCD patients and whether that NCD patient has a need of health need or anything, so that we can use these health extension workers to strengthen this community engagement. So more to engage to the communities or while going to house and so on. So I recommend and my team recommend these health extension workers more to involve, to engage the community. Thank you so much.
Very good. Thank you so much, Bezawit. To Dr. Desalegn, I think if you could comment on remdesivir as well, and secondly, is there any strategy to improve NCD service utilization, especially during this difficult time? Is there any targeted strategy from, let's say, and guidance from the Ministry of Health on this, or for that matter, from the hospital? And secondly, is there any strategy to reach out to patients at home by health professionals? If there is no, why not? And what is it that you guys are envisioning in as far as providing those services are concerned? These are three questions to you.
Thank you. As far as I know, remdesivir is not available in Ethiopia. It is an expensive drug developed by Gilead, and the consumption is still in developed countries is not satisfied, and it's not available. And say an expensive drug, and it's not available. Regarding non-communicable disease care and treatment in this country, it's not yet, the program is not yet mature. So there is no registry, there is no established registry for non-communicable disease. Though there are initiatives in chronic rheumatic heart disease that works well, but in other diseases, there is no established registry. Second, there is no means that back referral systems are established. For example, I can't refer back a diabetic patient to the lower facility through the system for further follow-up and continuation. The other thing is non-communicable diseases by nature are polymorbid. One patient to have multiple problems. For example, a patient can have diabetes, hypertension, asthma, heart failure, and so on, that requires a specialist care, and it cannot be handled by a health extension worker or in a primary healthcare services, because the healthcare service by its nature not yet matured. Laboratories are not there to determine their blood sugar, renal function test, electrolytes, the lipid profile, and monitoring services. And there is no also a system established. So as a response for a COVID response, the best way that we can manage this patient is through virtual clinic or phone clinic services. So that should be documented. For example, our phone clinics are like the virtual clinics that every complaint of the patient is documented on patient's record. It's not like a call center service, but the information that was delivered to the patient's complaints and the treatments prescribed are documented in the registration, in the patient's electronic medical registration that can be run by a professional, a healthcare professional. So if we promote this virtual facility, it's important to reach more patients. The other thing is we are not also screening. We are not now screening patients with hypertension. We are not screening diabetic patients. We are not screening cervical cancer. We are not screening breast cancer. So a lot of patients are still getting complicated. So this should be also reactivated and reinitiated. The other challenge that we are facing is when a patient from a region, like for example, a patient may be in the regional town, and when we tell the patient, collect your medications from the local hospital, and the local hospital says that your follow-up is in into Kurambasa Black Line Hospital, you have to go there and collect your medications there. So we have tried to solve this problem by writing a letter. The Ministry of Health write a letter to cooperate in this critical period to those patients who are not even belong to your domain. You have to supply medications and so on. So we are working on this, and a lot is expected from partners as well, those who are working on non-communicable diseases, to take patients as cohorts, and we have to ask each patient on the record what happened to him or her. Thank you.
Excellent. Thank you so much. That's quite useful. So the last question is to Dr. Yosef. Dr. Yosef, and obviously, you know, the rest of you may also comment on this. Is there any lesson that we've learned from HIV/AIDS to inform our COVID and NCD response in this country? Could there be any lesson that we can be able to draw on that? So Dr. Yosef and the rest of you could as well comment on that.
Well, I don't know exactly how lesson learned. Actually, HIV, as you know, is a chronic problem, a chronic disease, more like NCDs. And COVID is an acute illness and an epidemic. So there is some difference, but of course, we learn a lot of things from chronic care model that we can replicate to an acute care. But one thing I would like to say with regard to the response to COVID, something that I should say, I think one area is the investment on PCR and testing. We have somehow to make that the cost benefit, to calculate the cost benefit there, and probably go to antibody and antigen testings if those are available. The other thing is with regard to mainly what we can do for COVID is a supportive management and our setup. And I think particularly we have to focus, probably Dr. Dassalo also can comment on that, more we have to focus on patients, admitting patients who are really need admission, need oxygen or other support, like you know, if they have problems with coagulopathy, complications, either it's a respiratory failure or it is a coagulopathy problem. So rather than admitting mildly sick, moderately sick patient, as we sometimes see. The other point I want to raise is, as a supplement to Dr. Dassalo, we need a system whereby big hospitals like Black Line and other teaching hospitals are benefit from the help by primary care. Very rightly, he said specialist care is needed in NCDs because of the polymorbid nature. But there are a lot of patients who go to big hospitals just for a refill of medication, and most of the time not for their evaluation. So their visit has to be spaced so that they don't waste time, money on traveling, and also the waiting time is also frustrating and one reason for loss to follow-up. So the big hospitals benefit by transferring out, but this system, of course, has to be created. This is the best way to do it. Also, patients' access for medication and other not sophisticated assistance can be delivered at district, primary hospital, and even health centers. In the future, we are even recommending and thinking of, you know, health posts where patients can get just a refill. They don't have to come every month or every 2 weeks for a refill of medication, but they would have their scheduled appointments for evaluation, 6 months, some of them need only a year's evaluation. Thank you.
Thank you so much. Well, I think, thank you indeed. We have Wenderson, I think, thank you Bezawit for connecting him with us. So Wenderson, can you, Wenderson is from the Addis Ababa Regional Health Bureau, and he's the NCD coordinator for the city where basically we have the highest hit of COVID-19. So Wenderson, you have 8 minutes. Welcome to this session, and can you please share with us your talk, please? Dr. Yosef, if you can.
First of all, I want to thank the coordinators, but sorry for the timing, the inconvenience of the network in my area. As we know, nowadays the government of Ethiopia mainly gives emphasis on the control and prevention of COVID-19. In addition to this, the Ministry of Health and Regional Health Bureau actively working on essential health services, especially focusing on non-communicable disease patients due to the nature of COVID-19. Its severity and morbidity and mortality is higher on people living with non-communicable disease than other patients. So, by considering this, our Regional Health Bureau bring an activities like supportive supervision performed in collaboration with the Ministry of Health and some partners which are working on non-communicable disease facilities to continue the treatment and prevention activities without any interruption. And house-to-house awareness creation was done by urban health extension professionals who are screening COVID-19 in his community. The other thing, in addition to house-to-house visiting, by using mass media through television and radio, the presence and service availability is announced for the public to come in the health facility and get their treatment without any interruption. We also weekly performance done with the health facilities to monitor the facilities what they have done in their facilities. Even if it is not cover all health facilities, our health bureau with some non-governmental organizations provide personal protective equipment like sanitizer, alcohol, face mask, gloves, and soap to the health providers working in non-communicable disease to perform their work without any fear. Concerning service provision, all non-communicable disease services are available in separate place from COVID-19 centers. The COVID-19 centers are alone working for the COVID-19, but other facilities working non-communicable disease in their facilities. There are so many challenges encountered during this time for non-communicable disease activities. One of these is facility-related challenges. The first one is there is high workload in the most health facilities and more focus given to COVID-19 prevention and control. At the beginning of the COVID pandemic, or at the beginning of this disease, there was a high fear of professionals, or there is panic in the health professionals. So people do not want to work in non-communicable disease facilities because of fear of the disease. The lack of separate room is the most problem in most health facilities because there is no that much space in most health facilities. So there is no alone services given in most health facilities in our regions. Drug and laboratory reagent interruption is a severe problem, especially nowadays. There are so many facilities to stock out of drugs, laboratory reagents. There is also shortage of medical equipment like blood pressure apparatus, chemistry machines, CBC machines, X-ray, ultrasound. All of these medical equipment are very seriously shortage in our region, especially in health centers, there is no these materials. The second one, inpatient-related challenge. Fear of acquiring COVID-19 from health facility is the first one. At the beginning of these days, most of the patients are waiting in their houses. Fear of when they are going to health facility, they are fearing acquiring this disease from the health facility. And the second one is lack of money to buy the drugs. Instead, they want to buy or purchase foods instead of medicines because they are feeling of hunger for the coming days are not known. There are suggested improvements in non-communicable disease. We should better give more emphasis on these activities, especially non-communicable disease are more dangerous for these patients when they are exposed to COVID-19. They are severely attacked by this disease, so we should give more emphasis for these activities. It's better to motivate even the health providers working in the facilities by different methods, giving training, giving awareness about the nature of the disease, how to prevent it, and giving more materials for them is very much important because there is shortage of PPE materials in most health facilities. So most health professionals are nowadays exposed to this disease. It's better to give or avail all these PPE materials for any health professionals working in the facility, even working in the community, especially urban health extension professionals. They are prone to expose for this kind of disease. There is maintain the availability of drugs, laboratory reagents, and medical equipment is the most important thing for all health facilities to give better health services. Strengthening the mentorship activities also the best and most important thing is for all health facilities. Contact patients by telephone calls, as Dr. Fellow said, it's better and more emphasis should be given appropriate counseling for them who are sick in their homes, and they should come to the health facilities and get their counseling and treatment appropriately. But we should communicate them with a telephone conversation because so many people are nowadays afraid of the disease acquiring from the health facility. So it's better to counsel them and give enough information how to come to the health facility, how to protect them from this kind of disease. It's better to give and use telephone conversation.
Wenderson, you have just 2 minutes.
Okay, I have already finished. Bringing the awareness creation by health extension professionals is the main thing. It's better to give awareness home to home for any person. Most of the people know how to prevent the COVID-19, but in practice, they are not delivered it, they are not practiced it. So it's better to demonstrate how to prevent the COVID-19 from acquiring this disease. Continue media announcements about service readiness and availability is very much important, and we should emphasize on these activities, ensuring availability of personal protective equipment. These are the very important things because nowadays most of the professionals working in health facility, even in the community, are affected by this disease. Thank you very much. I have already finished.
That's very good. Thank you so much. And thank you so much, Bezawit, for an excellent intervention to rescue us. There are a few more questions that were actually flagged here. The first question is for every one of you, basically. Does fear to visit health facility due to COVID-19 justifiable? It's not necessarily within your frame of presentation, but however, these are important questions. Is there any experience using steroid for COVID patients? And another general question, when would it be the case that 14 days quarantine be lifted so that, we can come to Ethiopia? Ruari, you wanted to also flag one more question that could be shared between the panelists. Okay, so So these are questions, and meanwhile, you can use this opportunity also to just make a final kind of word with respect to today's presentation within the remaining few minutes. So first, Dr. Adamu.
Thank you once again, Dr. Mergisa. I think the concern of patients with NCDs, when whether they should come to health facilities or not, I think the concern is valid. Generally, we all should be cautious, right? So they should be cautious in general terms, but patients with non-communicable diseases should have extra caution. So that's important. So what transport do they use? What measures should they take to keep themselves safe is important. So they shouldn't avoid health facilities all in all, but they should take the precaution measures and maybe talk to the facilities ahead of time before visiting, because the repercussions could be worse. But I think the clinicians should maybe comment more on that. About the quarantine, the 14 days quarantine, when should it be, or when would it be over? It is something difficult to tell at the moment, because we are climbing up the curve at the moment. So it depends, and we are still doing contact tracing within Addis. So the same will follow. Even if the situation's improved, I think we might still have the quarantine for a while for the safety of all of us. So I would say stay tuned and let's see what the evidences would tell us in the coming weeks. Otherwise, my general remark is about health facility resilience. I think we need to think seriously about the resilience of health facilities, not right after the pandemic or the emergency, but even before. So these preparations should be a learning curve, so that even post-COVID, we need health facilities should be capacitated to be resilient in such circumstances, so that essential services would continue. And I think there are some documents coming up from WHO and so the like to do so. So I would like to advocate for resilience at health facilities at all levels, not only hospitals, but as mentioned by my colleagues. Thank you very much.
So thank you indeed. It looks like we have only 2 minutes, guys. It was an excellent session, absolutely bound by time. We have to close this down, despite the fact that you may have some words to say, but I am allowed to just finish it in time. And I would like to thank everyone for participation. The quarantine part, obviously, we have given some advisory, caution about it. Government may come out and give some direction on that one. So stay tuned, as Adam said. Otherwise, I will, this is a very good opportunity for us to collaborate with all partners involved in today's session. Thank you indeed from my side, and I'll get you back to Hala and team. Thank you indeed. Have a great evening and day.
Okay. Hala. Thank you very much, Mergisa, and thank you to all the speakers for this amazing panel and for sharing all those lessons and insights. We hope to see you again in our coming webinars. Also, thanks to GIZ and THET for co-hosting this webinar with us, and we look forward for more collaborations in the future. Next week's webinar will be about malnutrition across the spectrum and the increased health risks during the COVID-19 pandemic. If you have any questions, please send them to our email, info@esther.eu, and thanks to all the attendees for joining and interacting during this webinar. We hope to see you again in the coming webinars. The recording of this webinar will be available in our YouTube channels, newsletters, and websites, ESTHER Global Health, ESTHER and IGHN. And don't forget to check our COVID-19 portal. Thanks everyone, and stay safe. See you next week.